Hello everyone, I'm Dr. Ali Bozorgi, cardiac electrophysiologist, and very welcome back to ECG Refresher Part 12. Today, I'll be sharing an interesting case of a 75-year-old lady with a medical history of diabetes and hypertension equipped with a dual-chamber pacemaker. She recently attended a follow-up appointment, and during this session, ECG Holter tracings and 12-lead ECG were obtained. The main question at hand revolved around the rhythm observed. Was it atrial fibrillation or not? Given her elevated CHADSVASC score, if it was AF, we should consider anticoagulant therapy. I encourage to pause for a moment, carefully inspect Holter and surface ECG, and in a few moments I'll provide you with an in-depth breakdown of what we are seeing. Beginning with the ECG Holter, irregular rhythm lacking visible P waves were evident with no discernible pacing spikes. The machine initially interpreted it as PAC, premature atrial contractions, a common occurrence in atrial fibrillation Holters. The Holter readings heightened suspicion of having atrial fibrillation. Now turning attention to our surface ECG. Pacing spikes are noticeable, yet certainty about their connection to P waves was elusive. Some deflections following spikes resembles P waves, but this wasn't consistent throughout the ECG. Additionally, irregularities in the ECG and in QRS complexes, such as here, were observed. The suspicion of atrial fibrillation persisted, but the possibility of atrial pacing with intermittent PACs was also considered. To confirm our diagnosis, we turned to the patient's device analysis. The patient had a dual-chamber pacemaker in DDDR mode with a lower rate of 70 per minute and upper track rate of 120 per minute. Interestingly, there were no recorded atrial tachycardia or atrial fibrillation episodes in the device recording system. Importantly, 98.2% atrial pacing ventricular sensing indicated probable 6 sinus syndrome, necessitating atrial pacing to maintain a rate of at least 70 per minute. Further analysis of the device data revealed a P wave amplitude between 2.8 to 4 millivolts, making atrial fibrillation improbable. Finally, pacing the atrium during threshold capture demonstrated complete atrial pacing, conclusively ruling out atrial fibrillation. In summary, the patient was diagnosed with 6 sinus syndrome requiring atrial pacing. The small P wave amplitude and the prolonged latency made P wave challenging to discern on the ECG. In the Holter analysis, pacing spikes were likely filtered out by the algorithm of the Holter machine. For a more detailed exploration of this case, please visit cardiocase.com, case 593, courtesy of Professor Ibrahim Nematipour. Stay tuned for our upcoming videos where we will delve into more fascinating ECG insight. Thank you for joining us, and until the next time.